Good afternoon, everybody. Good morning still, and welcome to the fourth and the last live case of GIS valve. I have with me a great panelist, and also I will introduce each one of them, but also we have the team ready since we are 15 minutes late to start. I have to my right, Dr. Abdullah Al-Mugheri from Prince Sultan Cardiac Center. I have also Dr. Ahmed Saeed from Cairo. I have Dr. Ziad Ghazal from the American University of Beirut. To my left, Dr. Abdurrahman Al-Qahtani from King Fahd Medical City. Dr. Anas Mirdad from National Guard Jeddah, and Dr. Fras Al-Ani from the American Hospital in Dubai. The highlight, the team will present the case. The highlight of the case is bicuspid valve with sizing. We're gonna also discuss briefly the low gradient aortic stenosis. So do we have the team ready? Okay, while the team... welcome Dr. Saleh and Dr. Saleh Khoj and Dr. Ismail Al-Zahrani from Ismail Al-Ghamdi from King Abdullah Medical City in Mecca. Can you hear us, Saleh?
Yes, we do. Yes, we do.
Okay, so we have with me a list of panelists that are introduced before, and I'm going to introduce again Dr. Abdurrahman Al-Mugheri, Dr. Ahmed Al-Saeed, Dr. Ziad Ghazal, Abdurrahman Al-Qahtani, Anas Mirdad, and Dr. Fras Al-Ani. Saleh, would you like to go ahead and present your case and your team in Mecca?
Yes, sure. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for having us. I would like to thank GIS for this kind invitation, and thank you, Dr. Fawad and Tayri. Let me introduce the team. On my right-hand side, Dr. Ismail Al-Ghamdi, Afsal, Main, Dr. Ahmed Bawadir, and Dr. Ahmed Fadil, our cardiac anesthesia, and Malik, who will be preparing our valve. Dr. Ismail, please present the case.
I have a patient with significant for last 6 months with severe osteoporosis, bilateral severe osteoarthritis, gastric bypass surgery in 2016, and I have a history of thrombocytopenia after dialysis 150 to 120. Next.
We are encountering a bit of difficulty with the voice, Dr. Ismail.
Yes, and I have a history of shortness of breath, class 2 to 3 for the last 18 months. No angina, no syncope, diagnosed with severe symptomatic aortic stenosis 1 year ago, advised for TAVI, but patient declined due to high risk of worsening kidney function. He was following in our OBD, and patient agreed for intervention after starting dialysis. Accepted for TAVI after heart team discussion. Next. And this is his ECG showing sinus rating with narrow QRS complex and normal PR interval. Next. And this is parasternal long axis view showing calcified aortic valve with accelerated flow, and the velocity is 3 millimeter. Next. And aortic valve area is 0.7 centimeter and DVI 24. Maximum velocity was 3 millimeter and stroke volume index 28 ml and ejection fraction 55%. So he has normal ejection fraction with low flow, low gradient, severe AS, and his CT calcium score 3000. Next. And this is his CT coronaries, and it showed no significant coronary artery disease, and this is our usual approach in TAVI patient. Next. And this is the annular measurement. We have the annular perimeter here is 82, and the minimal diameter here is 20 with average 25, and here also LVOT perimeter 80. Next. This is the subannular measurement, which shows the membranous septal length around 5 millimeter, and there is a mild extension of calcium to the LVOT around 80 millimeter. Next. This is showed aorta is from 37 to 38 millimeter. And also we have adequate here height of the coronaries, right and left, both of them around 14 to 19. Next. This is the appearance of the valve, which showed bicuspid aortic valve with fusion of right and left, and calcified raphe also. Next. This is video showing from the annular to subannular with measurement. So we will see it in the next slide also. This is the movie for the supraannular valve around in 5 millimeter and 8 millimeter. Next. And here the measurement for annular, as we mentioned, it is 82, perimeter is 82, and in 5 millimeter supraannular it is 77, with intercommissural distance around 30. So we are comparing the size. We are between the 29 and 34. So if we put 34, it will be oversized 30%, and if 29, it will be 11%. Next. This is virtual valve for 29 versus 34. Move the second. Okay. And this is the peripheral. No issues, no significant calcification, no tortuosity, and both diameter in the right and left more than 80 millimeter. Now we'll go for Dr. Saleh to tell us about the setting of the patient.
Thank you, Dr. Ismail. So we usually go with the minimalistic approach, as most of the centers are doing. Conscious sedation, no central line. We have and usually go one femoral axis for the delivery of the valve, and the second axis is a radial. However, this patient have chronic kidney disease and on dialysis, and he might have an AV fistula later on for the dialysis, so we avoided touching his radials. So we have a left femoral for the pigtail and right femoral with the 14 French sheath for the delivery system. Also, we go with an LV pacing over the wire of the LV rather than RV pacing. So now we are at we have our three setup shots for the cusp overlap view and the coplanar hand. Yes.
Great presentation. I'm going to ask my colleague, Dr. Abdulrahman, to use the smart screen just to get the room engaged with the sizing. I'm going to start by Dr. Ghazal. Great case. If this is in your lab with this degree of hemodynamics, severe, not severe aortic stenosis, what will be your go-to modality to differentiate?
Yeah, so here we're dealing with this gentleman on dialysis who is presenting with what is referred to as low flow, low gradient, severe aortic stenosis. So this is all from the echocardiogram. What that means is severe aortic stenosis, by definition, is a valve area of equal or less than 1 centimeter square or indexed 0.6 centimeter square per meter square. So this is the definition of severe. Then we have low gradient, which is by definition mean gradient less than 40. In this patient, it's 21, mean gradient. And low flow, again, by definition, low flow has nothing to do with the ejection fraction per se. The definition of low flow has to do with the stroke volume index, which is less than 35 cc's or milliliter per meter square. So, and this patient stroke volume index, I think, was 27 So here we're dealing with a patient with low flow, low gradient, severe aortic stenosis. Now, when we come to the ejection fraction, you could have a low ejection fraction, or you have a normal ejection fraction of more than 50%. This patient has a normal ejection fraction. So this patient, to put it all together, has low flow, low gradient, severe aortic stenosis, ejection fraction higher than 50. This is called paradoxical. Paradoxical, low flow, low gradient, severe aortic stenosis. And this is as important as the true aortic stenosis that we're all familiar with, if the measurements are all done correctly. Done correctly meaning that you have to have a proper measurement of the LV outflow tract by echo, because a lot of the times it's underestimated. You have to have a good measurement of the continuous wave Doppler along the line of the aortic ejection of the aortic valve. And if it is all correct, like in this patient, we have to think why. There are two major possibilities. One of them is concentric remodeling. Small ventricle, the mass is the same, the thickness of the ventricle is the same, but the ratio of the wall is increased. You have a small cavity, and that means a low filling, gives you this type of impression. And other reasons, low preload, such as mitral stenosis, mitral regurgitation, tricuspid regurgitation, RV failure, and so on and so forth. So if you put it all together, you need to have all those parameters and think correctly. Are we dealing truly with a severe AS? Then you can resort to the calcium score. Calcium score is important. In this patient, it is high. So all that together confirms the possibility of severe aortic stenosis.
Thank you. Dr. Saleh, I see you already made your plan. Do you want to hear from the panel what they're going to, I see you planning to predilate. So may I just ask you, you summarize your plan initially. I'm just going to, you could continue to work, but I'm just going to ask Abdurrahman if he had the time just to go over the measurement again, and then I'm going to ask the panel what's their strategy individually for such case. We are dealing with the bicuspid, type 1. Dr. Abdurrahman, can you just reiterate again the measurement at the annular level?
Yes. So as they showed us in the presentation, that because this is what seems to be a bicuspid pattern, either a functional bicuspid or true bicuspid severe type 1, then you ought to take measurements at the level of the annulus and 4 millimeters above the annulus. So the barometer at the annulus level was about 82 millimeters. And when you go 4 millimeters up, you find that it's about 79.4. And when you take the measurement, when you try to assess your size, you have to take into consideration those factors. This is one of the shapes that you might get when you do an assessment of the bicuspid aortic valve, and this is called taper shape. If it's reversed, it's called flare shape, and if it's the same for the annulus and the intercommissural distance, at the intercommissural distance level is the tube shape. So based on this, you take the smaller measurement, which in this case is the one at the supraannular measurement. And this will give you a valve, and a core valve of 29. But if you consider this 82, this is at the measurement between the 29 and 34. So if you will take this measurement, you might be choosing either 29 or 34. But in those cases, you prefer to go with a smaller measurement, even though it's not the annulus measurement, it's more the intercommissural distance, which is a 29 millimeter core valve.
Okay, so Dr. Saleh, we went over the measurement quickly. We're going to pull the panel to see, first of all, Abdurrahman, predilate or no predilatation, what size valve?
I think the measurements is good to match it, because this is a bicuspid valve. It's not tricuspid, which you can take the measurement as it is. So if you take the alignment of the calcium and the bicuspid and the LVOT, so probably you go whether to same size or slightly undersize the valve to avoid the unfolding, the folding of the valve. If it is big, bigger than the and the bushing from the raphe, calcified raphe, it will be stayed, calcified, folded, and may interfere with the hemodynamics.
So pre-dilate?
I do not recommend
The size of the
this
valve
in
is
this case.
29, Dr. Ahmed?
Size maybe is
Okay, while they are coming back online.
This subtype of bicuspid anatomy is with taper type. I usually I respect the intercommissural distance, so I'll use an Evolute 29, and of course I'll predilate.
Okay, Dr. Zal.
Yes, I would pre-dilate because that commissure is thick and heavy. I just want to make sure it expands at least a little bit. I'm talking about the raphe. And as far as balloon versus self-expanding, the data is good for both. Balloon is a little bit more associated with annular rupture. Self-expanding is a little bit more associated with paravalvular leak. Here, as far as the size, if we want to choose a self-expanding, again, I would respect the fact that at the commissural is narrower, so I'll go with that. So probably 89 would be 29 would be the right thing to go.
Dr. Firas Al-Ani?
Yeah, I would definitely go with the 29 here and a self-expandable rather than a balloon. And I, it's important that the point about the BAV was brought up as whether you need to balloon or not. Again, this is, if you look at it, this is either more class 1 or type 1. And in general, I would lean towards balloon just for two reasons. One, it's a type 1 because they're usually more forgiving than a type 0 for balloon valvotomies, and also gives me a safety in not getting the nose of the valve get stuck on the way in.
So if Dr. Saleh back on, can you hear us?
Yes, we do.
Can you hear us?
Yes, Dr. Faisal, we can hear you.
Yeah, I cannot see you because the
Yes,
picture
yes,
is
we do.
frozen. Basically, the consensus here is predilate, yes. Again, the picture is gone. The size of the valve seems they are using the Bavard criteria. They are undersizing, respecting the calcified raphe and using a 29 millimeter valve. I do have a question from the floor or comment, but I'm not gonna stop you from working. Please go ahead, and if you are able to answer the question from the floor, otherwise we will divert it to our panelists.
So just a comment, some people will take the
Yes,
annular
we
and
are moving
subannular and divide by
ballooning.
2 to get the sizing. Sometimes you might use balloon, sequential balloon dilatation to give you the exact size. And then as I said, some people, they will do just the average of annular and subannular in the bicuspid aortic valve.
So,
Dr. Saleh, can you ask the cameraman to consent to depict the image of the valve deployment and the process rather than the image of the femoral?
so what size balloon, Dr. Saleh, you're using?
We are using the size 20 millimeter based on the minimal diameter of the annulus.
Okay.
Another one? Another big syringe, guys. Syringe only.
So you're pacing over.
Facing over the safari wire in the LV.
Can you show us the picture of the balloon inflated? Did you see that?
Please.
So there is no distinct.
Do you see the front of the angio?
It's a small balloon.
20 millimeter balloon, this is a small one.
Yeah.
What size of balloon did you use?
20 millimeter. So you chose the 20 millimeter
20 millimeter.
to respect the smallest diameter that you obtained by CT, which is the right thing to do. If we want to, just a question, if we want to use it for sizing, it may be already undersized to be able to use it for sizing, correct? If we don't see a dent, that means we probably cannot use it properly for sizing.
Okay, go ahead.
Question for the panel. Would you do angio with balloon? Because the raphe is left and right raphe, it might be you want to see the behavior towards the left main. So while inflating, I thought there would be angio just to see the behavior of the raphe. I think this is important in relation to the coronary.
Okay, so I will start by myself. Usually when I dilate for this anatomy, I use the RAO view. Personally, that's what I want to see, the relation to the balloon. And if I'm not dealing with a low-lying left main, I usually tend not to inject, unless I am between two sizes. But here, I think the size for a 29 was appropriate. So again, going by
For this particular case, I don't think the coronaries is an issue. You have white sinuses, you have high set coronaries, and the raphe between the right and the right and the left in this case is even protecting the leaflet from getting towards the ostium of the left main. So I don't think this is an issue in this particular case. But again, I'm emphasizing the point that Dr. Ziad was just highlighting. There are two uses of the balloon. One is pre-dilating, as in most of bicuspid cases. The other one is using the balloon for sizing, which the operators, I think, were not intending to use. They were planning ahead to use a 29 valve. And if you are just confused between two sizes, using a larger balloon and watching for the waist, maybe injecting the ascending aorta as well, to make sure that like a 22 millimeter balloon is sealing at the level of the intercommissural distance.
So Saleh, just because again, I'm not sure if the picture is frozen, or are you ready to deploy your valve?
I think the balloon, if we are using it for pre-dilatation, we have to take the size in consideration, because you want your aim of the balloon is to prepare the bed for the valve. So you have to take the size of the valve to make it for the planned valve, because if you are going to planning to deploy the 34, take the 25 at least balloon to make the bed for the valve to avoid the post dilatation, then the valve will expand well. But if it is just opening because the flow, low flow, low gradient, I did not expect a resistance from this to obstruct the flow from the valve.
Because there is no, if you allow me, there is no nothing
Live
to
transmission,
see.
yes.
But I thought this is an opportunity to ask this relevant question. The patient has low flow, low gradient, small ventricle. Is that a precursor of we're discussing outside experience of suicidal ventricle? So I think they need to fill it in with a lot of fluid, particularly before the balloon, because that's the time when you balloon them, you might suddenly reduce the afterload, and then you might go into complete obliteration of the ventricle. So I thought these cases are very important. Concentric LVH, low flow, low gradient, you need to fill them in a lot with IV fluids to prevent that disasters.
That's a great comment. Let me ask Abdulrahman, have you seen suicide ventricle with a low gradient? Paradoxically, you have seen it with the critical, yes, but again,
As a rule of thumb, actually, this is kind of a prerequisite when we do those low flow, low gradient, because you do run the risk of suicide ventricle. You don't commonly see it with the balloon, but after you put the valve in and the patient is not properly filled in, and you have this massive LVH and contractility, then you run that risk. So some people do not perceive this as a risk, but once it happens, if you don't recognize actually what's going on, and if you don't treat it properly, as if a patient is going into an obstructive Hawking pictures and trying to fill with an afterload, increase the afterload with phenylephrine and flush them in, then you might lose patient that way. So in cases like this, I personally make it a prerequisite to fill my patient in before even we do anything.
Dr. Faraz.
Yeah, just a quick comment on that. I know it's very important to fill the ventricle. Thank you for bringing up the LV suicide. But if you face the LV suicide, it's very important how to manage it. Fluids will get you a solution, but it's not a quick solution. It's very important to avoid inotropic or any drug that give you a beta agonist. Stick with, obviously, alpha agonists. And make sure you talk to your anesthesiologist beforehand as you go into the case, because even though we do this under local anesthetics, but anesthesiologist tends to kind of be very fluent with dopamine and dobutamine, which is a bad drug to use in LV suicide.
Okay, while we are getting the team back, I think we have a question from the floor, but let me direct this very important question to Dr. Anas. We see this report of paradoxically low gradient severe aortic stenosis. What are the echo parameters? I know Dr. Razal went over some of them, but as an echo lab, do you usually ensure that that when you supply us with the measurement that you're already raising the point and you already excluded all the technical aspect of diagnosing a low gradient aortic stenosis, paradoxically low gradient.
Yeah, so thank you for the question. I think very important, as was previously stressed, to make sure that you are doing proper measurements. Before even checking the measurements, you should make sure that the patient is not extremely hypertensive, which can artificially kind of reduce your mean gradient or can reduce your mean gradient. Finally, you want to make sure that you have proper LVOT measurement, proper V1 and V2 measurements and traces. And then if you truly have low flow state, so this means a stroke volume index of less than 35, this means you have probably a low flow, low gradient AS. Another important point is that you should always try and obtain measurements from different angle. The right parasternal view is quite important in patients with aortic stenosis. If your sonographer is not obtaining right parasternal or using the PDOF probe, probably they're not working hard enough to get the highest gradient possible. Another thing is that usually patients with severe aortic stenosis, if they don't drop their ejection fraction, they're not going to have less severe AS. So make sure that
Dr. Saleh, can you ask the cameraman
Can you just show us the screen, please? Thanks. You were, sorry, Dr. I interrupt you.
Yeah, show us the screen, please.
Yes.
Let's go down.
We
Can
did
you
not
hear
see
us,
the
Dr.
valve, just
Saleh?
only we're seeing the femoral, your hands.
Yes, Dr. Faisal. Okay. Can you see the screens?
No, we see you very well, and we just want to see the screen. I see that you start deploying. If you just take us through the views during your deployment.
Ziad?
If you are in a moment where you can share it hemodynamically.
Are you fully deployed or not yet?
No, at 80%.
No, not yet. No.
Okay, so we would love to see the screen.
The fluoro screen, Dr. Saleh.
Yes. Do they see it now? Do you see the screen?
No, we didn't see it.
Allah, Ziad.
Ziad, please.
Slowly.
خليه يعمل.
Don't press. Stop. Slowly. Slow.
So now you're deploying.
Can they move the camera from the direction to the hand to the screen? Who's holding the camera?
So, Dr. Saleh, if they are not able to show us the screen, just walk us through what you are doing right now, if you are able to talk at this moment.
We are opening the valve at the first phase. Yes. Slowly. Test. We are in the cusp overlap view now. Open.
If it would be nice that your cameraman just direct us towards the screen.
Yeah, can your cameraman direct it to the fluoroscopy screen? No, not that screen.
The camera.
To take this opportunity, because I heard the comment of the annular ruptures with balloon. I reviewed the literature, I did not find this one. I find the rupture with the self-expandable is more. In one of the studies comparing 1-to-1, head-to-head, it's the rupture happened in one self-expandable because of the post-dilatation and the no reported cases with the, from that study with the balloon expandable. This is just the observation.
Okay, Dr. Ahmed.
So, suicidal ventricle, I'm very scared of this complication. I have seen it once, and we really struggled with the patient to survive. When I suspect a suicidal ventricle, I have two things to do, to be honest. I put a central line. It's not very common to put a central line for the patient when I do, because I need dedicated fluid line. Second thing, I pace the patient. I just continually pacing the patient. That will paralyze the septum. At least one part of the heart is moving, the other part will not move. That will sometimes solve the problem with suicidal ventricle. I've seen it twice. Both of them survived, alhamdulillah, but they were very difficult.
Yeah, in addition to that is the medications combination, the balancing the afterload, the volume, it's during the, also in conjunction with the pacing.
I think a couple of comments here. Go ahead, Dr. Ahmed.
Go a little bit forward.
Until the team comes back.
RB pacing helps in these
يلا بسم الله.
excellent point.
For the suicide ventricle, I think, again, by the time we finish the procedure, like I looked at that 3 times over a period of 12 years, the anesthesia in average gives 1.2 liters. So that's why probably we are not seeing suicide ventricle. There's a follow-up comment. We didn't see you, Dr. Saleh, so you could talk to us. Balloon expandable versus self-expandable in bicuspid aortic valve. Balloon expandable, higher risk of rupture compared to self-expandable.
But in the studies I analyzed, they did not find this. They presented during the meeting in the Medina conference maybe 6 months ago.
So can the team hear us? So let me ask the panelists here, how many times, let's take the 1 year time, how many times did you use balloon sizing for a bicuspid valve? Starting with you, Abdullah, Abu Assam.
0.
0 here.
I sometimes use it when I have too much discrepancy between the intercommissural distance and in these taper types. Sometimes you have a parameter at the level of the intercommissural distance, which is like 60 something, and a very wide annulus, which is 90 something. In these cases, I don't feel confident to go for the small size before balloon interrogation. So sometimes in extreme taper types, I go for balloon interrogation just to make sure that I'm using the right valve.
Yeah, I don't use it for balloon sizing. Keep in mind, if you really want to properly use it for balloon sizing, it's just not a matter of using a small balloon and see if there is you have to use it sequentially. You see the dent, you don't see the dent, you go up with the size. That's also expensive and more laborious to do. But if you want to do it properly.
No balloon sizing?
No balloon sizing. I think we have robust data with CT-guided assessment, and it is enough to use that to guide you. Once you use sequential ballooning, then it becomes a subjective assessment. This is what I think the right side, your colleague may disagree. But if you're in doubt and you use a self-expanding valve, then the valve will just, as long as you're not in a gray zone where you're using a smaller valve versus a bigger valve. If you're confident about your sizing, then as a self-expandable will basically grow until to the right point. If you use balloon expandable, then if you're worried that you might overinflate or anything, so you could take 1 cc out and then you can post-dilate if you need to. But I don't do balloon sizing at all.
Yeah, I wouldn't do it again if we're using technology of self-expandable. And if I'm using a balloon expandable, like pointed out by my colleague, I might use it to decide which of the 2 smaller devices that I'm not going to use. So definitely undersize the balloon and to eliminate a smaller valve and go with a bigger one.
I think the live transmission took us to a different alley here, unfortunately. So rather than filling the time, I just wonder with this case specifically, type 1 calcified raphi, everybody probably, I shouldn't say everybody, but the majority here will predilate to test the compliance, not necessarily to size. But you have seen a case yesterday or presented a case yesterday with type 0. Would you treat type 0 any differently in this case, or you just the same rule apply, you still predilate all bicuspid valve? Again, this is a question to the panelists, and feel free to please join the discussion from the floor till we get the live transmission back.
I think the predilatation is a mandatory if the calcium at the raphe is very high. But if the calcium at the raphe is not very high and your sizing is good, probably with the balloon expandable, you didn't need the predilatation because this balloon will dilate itself. And you minimize the risk of embolizations and the stroke. But with the self-expandable, maybe you need it to prepare the bed in addition to that, taking in mind, keeping in mind the risk of strokes from the repeated balloons if you need.
So I think it depends on the pathology. Sometimes you have type 0 bicuspid with predominant aortic regurgitation. In these cases, I prefer balloon expandable in these cases, if they don't have too much calcium. And if the pathology is calcification and stenosis, I prefer self-expandable platforms with predilatation.
One comment regarding classification, it's always been very confusing to me because depending on what we use, there is type 0 and type 0 for one classification, maybe type 1 for another. I'd like to call it bicommissural, tricommissural, bicommissural, and that's one classification which is accepted. Bicommissural with RAFI, bicommissural without RAFI, and then tricommissural. One other point I'd like to make is that, like this case, if you have one, and that's the most common case, right-left RAFI, bicommissural, this is a RAFI which is very calcified. So we should expect that when, let's say, a well-sized balloon is inflated, or if you're going to put a balloon expandable stent with the adequate pressure to expand that stent, there is a tendency for that balloon to go into the pathway of least resistance, which is the non-coronary cusp. And that's where the perimembranous membrane and the His bundle is located. And this is more of a chance, more of a risk for conduction system disturbances in this particular type of, oh, there we go, you're back.
Saleh, congratulations,
Yes.
a great case.
You didn't see it.
Can you, can you just ask your cameraman to show us the screen and just walk us through what you did?
They closed already.
يلا يا زياد الله يرضى عليك.
If you didn't do that, you will not get the round of applause.
يلا يا زياد.
No signal.
I have a question.
from,
I do have a question. I just want to clarify one point. So we see those octogenarian or those in their 70s that present with a bicuspid bearing valve, which is likely functional bicuspid. And this is not a true bicuspid in a way. So would you still, who would treat it or size it based on a bicuspid technique, and who would use the regular sizing in those cases?
Okay.
Wait.
Okay, I will just go to Saleh. Are you able to show us, and then we'll answer this question, Abdulrahman. Are you able to show
Can
us
we
the
get closer?
fluoroscopy?
يا شباب يلا يا زياد. They will show it?
Go
Okay.
through the fluoroscopy.
يلا go back from Saeed, go back from the
2 minutes. 2
back,
minutes.
Okay.
back,
Please.
back from the
Can
deploy.
do you mind zooming?
Okay. Can you do zooming from here? From
It's
the
live
camera?
in a box.
Yes.
Do you see it
Still
now?
the same educational value.
Yeah, can you zoom
Can
more?
you zoom, please, Saleh?
Zoom all the way on that screen, please, all the way.
Great. And what
now
size
bring the
valve did
screen
you use
closer.
at the end?
Size 29.
Great. So can you show us the view after you deploy? Next.
Go back.
Okay.
So go back. Back.
Back one.
So this is the cusp overlap view.
Okay.
After opening the valve, maybe 60 to 70%. We were happy about that depth in the RAO caudal, in the cusp overlap. Go next view. Okay, next. So this is the coplanar angle to show the left.
Next. This one. Okay.
Again, we were happy about the depth. So it's around 3 millimeters if you look at the left cusp. Next.
That's really a high deployment. Great job. But
Next. 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 We are removing the parallax from the valve, and this is our final injection.
Next.
This is from, go back, sorry. This is from the LAO.
Yes.
So again, you can appreciate around 3 to 4 millimeters from the left cusp. Go next view. This is the cusp overlap, next. And this is the injection.
so this is the last view in the cusp overlap. And do you have one without the wire?
Not yet, so we'll take. Okay.
Great. So can you just show us your hemodynamics, Saleh, if it's possible, if you took some hemodynamics, and just show us the ECGs. Any changes in conduction?
ECG, there was a widening of the QRS after the ballooning, and it returned back to the narrow complex again after afterwards.
Do you have any hemodynamic screenshot for the EDB? If you don't, just let us know what's the gradient.
By the way, do you have a baseline gradient, hemodynamic gradient, by any chance?
No, we did not take an in-depth gradient.
Okay.
It was by the echo.
So do you have the gradient post-procedure, Saleh?
The echo is in the room now.
So you do not have a hemodynamic gradient?
Hemodynamically, no. We usually rely on the echo.
Sure. Okay. So AKG has been returned to baseline. It looks like your blood pressure, I don't see a wide diastolic gap here. Just waiting for the echo to tell us know what is the gradient. Did you do any panorama in the valve to see if there is any constraint?
We did not do that, but we did, before we get in with the valve under floor, we check the valve. Can you check show us the valve check? Yes.
Can you just show us the
So it
screen
was
of
loaded
the,
nicely.
the screen of the screen of the echo if possible?
Yeah, we take few minutes. Just take this one off. Okay. Just
Okay, I'm just worried that we're going to lose you, so I would like to congratulate you on a great case. And honestly, our thanks to you and your team. And we apologize for this technical issue. If we are still online, we would love to see the result by echo. I will take the comment.
yeah.
Yes.
But I promised you a round of applause, so I'm just going to start before you go. Great job to you and your team.
One short comment about the echo.
Thank you.
Especially in paradoxical low flow, low gradient, low flow, low gradient aortic stenosis, what's called ZVA, or the valvulo-arterial impedance. Not many echo labs, they do it. It's actually systolic blood pressure plus the mini gradient over the stroke volume indexed to the body surface area. And more than 5.5 signify severe aortic stenosis. This is when you are really confused about them, because you have low gradient,
online, yeah.
normal LV, and the valvulo-arterial impedance.
Okay. Would you like to comment, Dr. Anas, about this this parameter? I shouldn't say new, but I'm not sure every echo lab will do that.
Yeah, I think there is some data supporting that, but not robust enough to be in the guidelines, but it's been used before.
No, it's weird. Saleh, did you have the chance to show us the echo?
Working. Just 1 minute.
Go ahead, Dr. Hamid.
Question to you, Faisal. What would be your choice of platform in these cases, and how do you navigate your decision, to you and to the panelists?
I think to me and to all the panelists, we have not any, in terms of guidance per data, they are equal. I think for the taper one, bicuspid with calcified raphe, personally, I use the self-expanding. For the tube one or the zero, I prefer the balloon expandable. I will open the question to my colleague to the right and left to comment about an excellent question about the choice of the platform.
Where is the Shahid? انت اللي معهم؟
We see the fluoroscopy, which you showed it nicely, and very minimal depth in the left cusp. We just want to look at the echo. How much you graded you're getting?
Are you see the echo? Professor, are you able to see the echo?
Yeah, we are able to see the echo.
Dr. Faisal, as they're doing this, just a quick question. I would like to hear the opinion of the panelists in terms of the depth. Like we can see there is a 0 degree. I mean, you're, as an expert panelist, Would you go for that kind of depth, or you would like at least like 3 millimeter below? Just like to hear your insight from all the panelists.
Great. So we have two things to pull the panelists. We just want to look at the AI. If there is any AI, Saleh.
Show us the color. Camera a little bit.
No.
Where is Saeed? شاهد كاميرا. Show us the last.
Don't see any AI. Show us the short axis.
Do you have a mean gradient calculated or traced?
Gradient is good. 5 is the mean gradient.
Excellent.
Again, congratulations, Dr. Saleh, and your team for really an excellent case. I think we have we have one comment with Dr. Abhar.
Yeah, thank you very much. It was a very interesting case. I just have a few comments. Number one, what I have done probably a little bit differently. The sizing is an everlasting question. I think the 34 is out of the discussion, as far as I'm concerned, way too big. Even the 29 could be debated. If you have a 20 millimeter balloon, once you have the balloon there, why not injecting? If you see that a 20 millimeter balloon is sealing, then you know you can even go further down. I don't want to discuss the intercommissural distance versus the annulus, but you could see the annulus is not the structure that is determining the size of the valve. The second thing is what is very, very important when you size the balloon and when you do the final shot is whether you have an infold, which is happening with the oversized valve. An infold in bicuspid is unfortunately a little bit more often than in regular aortic stenosis, but a 34 in this one I think would have been not a good choice. You could even argue, I don't want to downsize too much, I understand that, but that question could be resolved with an injection in the 20 millimeter balloon, because the 20 millimeter balloon, you don't do much. You don't dilate that particular raphe, you don't break the raphe. You could even argue whether you create room for the valve. So why not using the balloon once it's there to see whether a 20 seals, and then you can even downsize a little bit more. Just a few comments.
Great, thank you. Go ahead,
Good thing in this valve, the size is good. From REO, from the LEO, the valve is well expanded. It's good. Probably the size is appropriate.
And for the depth of the implant?
The depth a little bit high, but maybe for future coronary is not good. But for the pacemaker and conduction, this one is good.
So you would take it?
Yeah, I would take it.
Okay, how about you, Dr. Ahmed?
I forgot one thing, so I'm sorry. Never look at one projection only. Always go around and see whether the valve is really expanded in a more or less symmetrical fashion. This is a good picture, but if you go over, then you might see something different.
Yeah, that's why we do the panorama. So go ahead, Dr. Ahmed.
I think the image is, there is some parallax in this image, so I can't decide whether we are really too high or not. So I'll go correct the parallax and go in right caudal view again, just to check how deep are we from the non-coronary cusp. So I can just tell it is high, but I can't tell if it is 0 level or it's just 1 millimeter below the annulus.
I think in the previous view, he was actually 1 to 2 millimeter in the non-coronary cusp. In the left cusp, the depth is in fact very
high for the bicuspid is good, by the way.
Yes. So any other comment from the panel? And go ahead.
So just responding
Ziad, is it working now, the last?
Just responding to Hamid's comment. I think the determinant, you could use the valve that you're more comfortable with in terms of relative, but there's certain situation where you have to kind of choose one. For example, a horizontal aorta, you will have more challenging when you have a self-expanding. This is a horizontal aorta. This is why you end up slightly higher on one side. So it will become sometimes challenging to put the valve in a proper way when you have a horizontal aorta. So balloon expandable will work. In terms of the in this situation, should you be okay with the valve sitting like this? Remember, the determinant of the size here was the intercommissural distance above. So there is a force that's exerted at the level above the annulus. So even though it's slightly high, you're still going to be having a stable valve because at the intercommissural distance, you still have this radial force on it. Thank you.
Dr. Mohammed.
Yeah, I think when it comes to the conduction abnormality, this is the best position because of the left-right raphe. That's the pressure will be back in towards the non-coronary right coronary commissure where the conduction abnormality or conduction system is there. So this position is ideal to reduce the chance of permanent pacemaker.
Thank you. I think we have one more comment. Go ahead.
So in terms of height, this is acceptable in all honesty for a bicuspid anatomy. The only price you pay is if you have to go for a post-dilatation. So, and this is not uncommon with bicuspids, but we know we want to implant them high. So we really have to balance between the chances of ending up at a zero level and having to do a post-dil, which obviously becomes a bit dangerous. Second point about the choice of valve platform, we're so much focused on the type, which is important, of bicuspid anatomy, but I think it's more about the pattern and severity of calcification. It's not only the severity, it's also the pattern. And you really want to understand the anatomy of the root and how that will behave with the valve platform you're using. So if you're using a balloon expanding valve that is 26 or 29, you want to understand how that calcium is going to behave along that stand plate platform and with the aortic root. Similarly with a balloon expanding platform. So just mentioning severity of calcification or type of bicuspid valve is not important. Just figure out how this calcium is going to behave.
Great comment. I think we are coming to the conclusion of the session. I would like to thank all the panelists, the team from Makkah, Dr. Saleh, Dr. Ismail, our audience for the great interaction, and sorry for the technical difficulty.
Thank you.
Thank you. Thank you.
جزاكم الله خير.
جزاكم الله خير يا اخوان جميعا.
يلا